Today we're going to begin our discussion of pain and the drugs that are used to treat pain. And in this particular lecture, we're going to talk about the pathophysiology of pain. And then in the next set of lectures, we'll talk about drugs that are used to treat pain along the way. Just a note, make sure you look at Brightspace. You'll find the lecture objectives there, and you'll want to use those as part of your study aids. As I always tell students, we'll present the information, but then go ahead and study the way you have learned to study, and then look at the objectives and ask yourself, can I respond to questions based on these objectives? Our outline for this particular video will be to cover 4 topics. First, the type and function of pain, the 3 pain circuits, the peripheral pain circuit, the spinal pain circuit, and lastly, the brain or the central pain circuit, which is actually the circuit where opioids have their action. So we're going to begin by a discussion of classification of pain, and that is, this is the types of pain. And so the first type of pain that we might come across is acute pain. This is pain that is very short-lived. It's usually as a result of an injury or some post-operative event, a surgical procedure. And so injury or insult has led to some acute damage to a tissue that is generating the pain, and that pain is usually short-lived. Chronic pain is pain that lasts for greater than 3 months. And there are multiple sources of chronic pain. One can be what's known as nociceptive pain. Usually this is a result of some sort of inflammation or an inflammatory condition like osteoarthritis or rheumatoid arthritis listed here. And then we also can have neuropathic pain. This is of neuronal origin or neurogenic. And so it can occur from a central mechanism as a result of a stroke or neurodegenerative disease like multiple sclerosis, spinal cord injury. And then peripheral neuropathic pain is usually the result of either a infection, a viral infection, in this case post-herpetic neuralgia, or diabetic neuropathy, and that is that the origin of the pain is coming from some peripheral source, and we'll talk a little bit more about what that is in a moment. There can be visceral pain, which is pain or pressure that's occurring around internal organs. Pancreatitis, inflammatory bowel syndrome would all be examples of where we might have inflammatory visceral pain. And then lastly, there's a whole bunch of pain that can be chronic pain that is mixed in origin. Lower back pain, which affects 55 million people, cancer pain, fibromyalgia are all examples of pain. And so at the highest level, we would be looking at acute and chronic pain, pain lasting greater than 3 months. And then really what we want to think about is appropriate pain assessment and making sure that we're thinking about adequate pain management. This is considered a standard of care, and pain sometimes is actually considered a 5th vital sign. The 4 core vital signs: heart rate, blood pressure, respiration, and temperature. And then levels of pain can be considered also a vital sign. So what are really the functions of pain? The functions of pain really are really twofold. One, it's really a warning system to allow you to avoid injury. It's telling you that this is a potential damaging situation and you want to avoid it. Pain also serves as an aid in repair. It creates that hypersensitivity. An area becomes particularly sensitive to pain, very tender, and the pain becomes more pronounced. It's really sending a message to your brain to tell you to avoid using this area or to avoid the stimulus that's causing the pain, to allow for this tissue to repair itself. And sometimes, though, there can be pain that is neither a warning system or aiding in repair, and the inflammation associated with that pain can actually become maladaptive, and that is that it actually may lead to more damage. And so pain, if you really think about it, has these two core functions as a warning system and as aiding in repair so that you avoid a particular area. And your goal then is a balance between having no pain, if you're trying to treat a particular kind of pain. Is it your goal to have no pain, or is your goal to just make the pain more tolerable? And that starts with a characterization of the pain by the patient. And so you'll ask questions about the pain. What is the severity of the pain? How long has it lasted? What was the onset? What was the duration? Did it start? And what's its pattern been? What's the intensity? We might see examples of pain scales like this, for an adult, where you might ask on a scale of 1 to 10, 10 being the most agonizing pain, and 0 being no pain at all. On a scale of 1 to 10, what does that pain look like? For a child, it might be assigning an emoji or a face to the type of pain that you're seeing here. And so that helps in the assessment of the intensity of the pain. What is the localization of the pain? Is it very focused? Is it generalized? Is it referred? Referred pain is the kind of pain that you might experience that comes about from another area of the body, and it's referring to another area. So in the case of a myocardial infarction or myocardial ischemia, the pain begins to distribute down the arm. You may see right-sided pain. You may see jaw pain, pain in the epigastrium and in the back. These are all referred pains as a result of that myocardial ischemia. Is the pain superficial? Is it deep? And then, as we'll talk in the next lecture, you may also experience what's known as opioid-induced hyperalgesia. This is a situation where chronic use of opioids causes pain to be worse and more emphasized. Hyperalgesia, meaning excessive pain as a result of an adaptive response that occurs as a result of opioid treatment. And lastly, what's the quality of the pain? This may give you some sense of what the source of the pain is. Is it inflammatory? Is it a throbbing or pulsating? Is it a stabbing, shooting, or burning, tingling pain that's very indicative of neuropathic pain? Or is it just feel like a pressure or a squeezing? And so understanding these four features, the temporal features, the intensity of the pain, the location, and the quality of the pain can help you in developing a strategy to treat the pain, either to have no pain or to make the pain tolerable. Again, as you might imagine, there is a significant subjectiveness to this pain. And so abusers who are seeking out opioid narcotics, for example, know that they can present the subjective elements of pain and seek opiates in this way. And lastly, it's just important to remember that pain is an emotional, has an emotional component and certainly impacts mood. And we'll talk about why that is when we talk about the central brain circuits in a moment. Okay, so let's talk about the brain circuitry that has to do with conduction of pain. And it starts here in the periphery. And so you start with a peripheral stimulus of some sort, trauma, damage, inflammation, and then the signal is conducted into the spinal cord, where the signal is processed here in the spinal cord, and then that information is sent in an ascending input up to the brain for processing, and this is the central effect. And then the information is sent back down in what's known as descending modulation to help control here in the spinal cord the action of this afferent neuron that is bringing information into the spinal cord, that's transmitting that pain-generating signal into the spinal cord. And so summarized on the right-hand side of this slide, there's an activation of some peripheral nervous system, there's transmission into the spinal cord, and then there's information that goes up into the brain for processing and back down into the spinal cord for modulation. And so we want to start by understanding these peripheral inputs and the peripheral circuitry that influences pain. Out in the periphery, at the skin, for example, there are numerous inputs and receptors that exist here in the periphery. There are what's known as temperature-sensitive receptors, the TRPV channels, or the TRPM channels. These are transient receptor potential cation channels, typically conducting sodium, potassium, or calcium. The TRPV, the vanilloid type receptor, is sensitive to heat and also spice, so capsaicin from spicy food, or cold. We might see menthol as an example of giving that cold sensation. These are all peripheral sensors in the skin. Then there are acid sensing receptors here. They're activated by protons, and these channels conduct sodium. These are the acid sensing ion channels. We have pressure receptors that are going to sense pressure, or in this case, if you were to be hit with a hammer or the initial poke of a needle piercing the skin, they're sensing that pressure and sending information into this afferent neuron going into the spinal cord. Lastly, there are several chemical irritants and chemical receptors here for a whole series of neuropeptides and small molecules. Bradykinin is one, histamine is one, all can be released in these peripheral areas. And so when we look out here at these periphery and peripheral receptors, when there is trauma, the receptors can be activated, but there's also a release of a whole host of inflammatory mediators, such as prostaglandins, bradykinin. Potassium levels actually go up, all of which can stimulate that afferent neuron to send a signal into the spinal cord. So we have these receptors that send this information into the spinal cord, where it is processed. And so in a real simple example here, here is the periphery, here is the skin, and here is that afferent neuron carrying the signal into the spinal cord. And in some cases, there is a reflex upon a painful stimuli. When you experience something sharp or when you experience something hot, this does not require central nervous system processing. That is, the signal does not need to go to the brain for processing. And the input comes in, and there's a reflex arc that sends that information immediately back out to the muscle to stimulate the muscle to act, to withdraw your hand from a hot surface or to move your hand or your foot from a sharp object. And so there is this reflex that can bypass the central nervous system and just go right back out to the muscle. So the nerve transmission from the periphery to the spinal cord, as I've said, involves many different ion channels. At the periphery itself, where this original stimulus occurs, there are these various ion channels that we talked about, the TRP channels, the acid sensing channels. And along the way, this peripheral afferent neuron is sending its signal towards the spinal cord. Along this axon, notice there are sodium and potassium channels that are responsible for conducting the action potential. Sodium channels like 1.1, the 1.6, the 1.7, and the 1.8 variant are important for conduction of pain signals along this axon. In particular, sodium channel 1.8 is a very important channel in the conduction of pain signals, and as we'll talk a little later, is an important potential drug target to block pain signals by using a non-opioid mechanism. And so you have this conduction of signal into the spinal cord, and once we get into the spinal cord, we see that there is a release of neurotransmitters, and in particularly glutamate. Glutamate being the major excitatory neurotransmitter in the brain, glutamate plays a really important role in conduction of pain here in the spinal cord. And the glutamate goes on to act on a variety of glutamate receptors, the AMPA and NMDA type glutamate receptors, which are ion channels, and then there are the mGluRs, the metabotropic glutamate receptors, which are 7 transmembrane domain G protein coupled glutamate receptors. And so we have that pain signal from a stimulus occurring out in the periphery. It's being conducted along by these sodium channels, glutamate released in the spinal cord that then sends this signal on to the brain for processing, or back out to the periphery in the example of a reflex arc, as we saw in the previous slide. So what do we know about the different pain fibers that transduce the different pain signals? There are 3 different pain fibers that we need to be aware of. First are the A-beta fibers. They're important for conducting stimuli that is non-noxious, that is not pain-producing, but just touch and pressure. So when you feel the touch or something pushing on your skin, that sensation is being conducted by the A-beta fibers. The A-beta fibers are have a thick coating of myelin, and they are very fast. They are not really involved with conduction of pain. The next fiber are the A-delta fibers. These fibers are involved with conduction of pain as well as the sensation of cold. They also are myelinated, but their myelin sheath is not as thick as the A-beta fibers. They are also fast, but a little bit slower than the A-beta fibers. And they are responsible really for that first pain, when you feel something sharp or prickly, sending that initial pain sensation into the brain. And then lastly are the C fibers. And the C fibers are really the ones involved with what we think of as prolonged pain. Temperature, touch, pressure, some itch as a result of histamine and inflammation. These fibers are unmyelinated and their conduction is slower, and they're really responsible for what we'd call the second pain, that dull, aching, nagging pain that persists. And so the 3 fibers, A-beta, A-delta, and C, all play an important role in conduction of sensations from the periphery into the spinal cord and ultimately into the brain. Now we want to talk just a little bit about peripheral sensitization and some changes that occur in the periphery around those receptors and in the spinal cord that play an important role in the long-term conduction of pain. What happens in the periphery with repeated stimuli, and there is reduced there is a reduced firing threshold. That means it becomes easier for a pain-conducting neuron to fire and conduct the painful stimuli. Peripheral sensitization, as we call it, that is, again, when there's this repeated stimulation that causes reduced firing threshold to allow an area to have more heightened pain response. All of this seems to be linked to a peptide known as substance P. And substance P is one of the neuropeptides that is released when there is an injury. And so when there's an insult of some sort, there is a stimulus, you get release of substance P, which stimulates areas in the blood to degranulate your mast cells. So it's stimulation on the blood vessels to cause vasodilation, degranulation of mast cells, release of histamine, and ultimately then the release of other inflammatory mediators such as prostaglandins and bradykinin. And so we've got substance P working here as a vasodilator. We've got it working, causing degranulation of mast cells, release of histamine, and ultimately release of inflammatory mediators such as the prostaglandins. Combined, these events lead to an increase in receptors, the signal receiving receptors here in the periphery, that then will ultimately send more signal into the spinal cord. And so this is known as peripheral sensitization. Sunburn is an example of when peripheral sensitization might occur. If you think about it, when you've had a sunburn, that area becomes very, very sensitive to touch. There's an adaptive response that has occurred in that tissue as a result of substance P release that causes the receptors, pain receptors and sensing receptors in those areas to become more pronounced, sending more signal and making that area very, very sensitive to touch. Now we want to talk more specifically about the pain circuitry that occurs in the spinal cord. Here in the spinal cord, we've already talked a little bit about the presence of glutamate receptors. And so this is the primary afferent bringing information in from the periphery. This is now in the spinal cord. When there is some sort of nerve injury, there can be peripheral nerve degeneration, or what's known as a neuroma. And a couple of things can occur. First, there can become spontaneous afferent activity. That is, that afferent neuron carrying the information in begins to fire. It's possibly due to enhanced expression of sodium channel subtypes contributing to enhanced cellular excitability and generation of ectopic action potentials. This means that these action potentials can occur on their own, and that's leading to this spontaneous activity, giving rise to the spontaneous sensation of pain, a shooting pain, a burning pain. We also know that there can be spinal sensitization. And so it can be some change here as a result of the neuropeptides being released, things like substance P, a neuropeptide known as calcitonin gene-related peptide, or CGRP, and glutamate. So CGRP, substance P, glutamate, all being released in the synapse in the spinal cord, leads to chemical changes and biochemical changes on the postsynaptic neuron in the spinal cord. and there can be increased levels of AMPA and NMDA receptors, and this increased expression leads to increased sensitivity. And so when these receptors, the metabotropic glutamate receptors, the neurokinin receptors, the CGRP receptors are activated. These are G protein coupled receptors. When their signal transduction pathways are activated, there's a change in biochemistry, an activation of protein kinase C that ultimately leads to an increase in AMPA and NMDA type glutamate receptors in the spinal cord, enhancing the excitability of this spinal neuron. This also enhances conduction of pain, and this leads to, again, enhanced pain as well as what's known as allodynia. Allodynia is a condition whereby a normally non-painful stimulus becomes very painful. For example, when a light touch, you would normally just perceive the pressure. A light touch actually generates pain. This is known as allodynia, and it's partly due to these neuropathic pain sensitization pathways that occur in the spinal cord as a result of increased AMPA and NMDA receptors. Lastly, we're going to talk about pain circuitry in the brain. This is the conduction from the spinal cord up into the actual brain for processing. And so, as we've said, there's peripheral injury that sends information in an afferent neuron into the spinal cord. Spinal cord then will send this information up to the brain for processing. As what we're going to see along these pathways, both going up to the brain and then back down to the periphery, there are high expressions of opioid receptors along these pathways. And so we see one potential point for opioid drugs and endogenous opioids to work, and that is here in the spinal cord, inhibiting transmission up into the brain. But as we're going to see, there's also opportunity in what's known as these descending pathways to modulate the pain signal. This slide actually illustrates this a little bit better. So we have a pain signal coming in, and again we've got that ascending pathway going up to the brain. And then there's processing of the signal in the brain itself in various areas. And then there's information that is sent back down through what's known as this descending pathway. The points where these red arrows are shown are all areas where there is mu opioid receptor expression. The mu opioid receptor is probably the more abundant one and plays probably the most important role in modulation of pain signals. And so in the central nervous system, activation of the mu opioid receptor will alter mood and produce sedation and reduces the emotional reaction to pain by impacting central nervous system processing. In the brain stem, the mu opioid receptor will increase activity of descending fibers, and as this activity of these descending fibers increases, it begins to influence this input neuron and this junction here in the spinal cord to begin to reduce activity of that ascending pathway. In the spinal cord itself, we can see some activity around vesicle release of neurotransmitters. We can see hyperpolarization of postsynaptic membranes. And then ultimately, a reduction in activation of that primary afferent and to some level modulation of immune activity. And so, as we will see in the next lecture, The mu opioid receptor is a main target of both drugs as well as endogenous opioids to modulate the pain pathway, particularly the perception of pain as well as the activation of this ascending pathway. And the descending pathway coming down modulates the perception of pain as well as the signal coming up into the brain to allow you to perceive pain. And then within the actual central nervous system itself, your brain processes pain in a lot of different areas. First, in parts of the cortex, it's giving you a sense of where is the pain? What is your perception of that pain? In areas known as the amygdala, it's giving you the processing of the feeling of pain, the emotion of pain, the anxiety of worrying about pain or feeling pain. In part of the prefrontal cortex, it's involved with decision making, and it's allowing you to process that pain signal in a way to determine what you will do as a result of the pain. And then in the nucleus accumbens, this is a really important area for dopamine and serotonin release. It's an important area for addiction. Opioid receptors here will impact dopamine release and play a role in the addictive property of opiates, but also some of the pleasure that's associated with opioid use. And so it's the constellation of brain areas that are impacted as a result of pain signals coming in that are modulated by the mu opioid receptor that gives you the overall sense of pain and perception of pain throughout your body. We're going to stop here in this discussion of pain circuits, and we'll pick back up in the next lecture as we talk about opioids.